Welcome to Ageless. I'm Dr. Jonquille Chantrey, and this is a podcast uncovering the truth about healthy aging, self-development, and medical aesthetics. Chronological age is merely the passing of time, but vascular age, our artery's true condition, paints a more telling portrait of our biological health. These discrepancies can spell the difference between vitality and vulnerability, with half of heart attacks happening to people with seemingly ideal cholesterol levels. Their arteries are already harbouring dangerous plaque despite a clean blood test. So it's clear to me that cholesterol as a marker by itself isn't enough. For women, these stakes intensify. After menopause, cardiovascular risk rises swiftly, and women begin catching up to men in heart disease rates, owing largely to the loss of estrogen's protective effects. Throughout my career, I've learned that true cardiovascular insight is too important to rest on a single number. Taking a holistic view, where hormones, inflammation, lipids, and lifestyle intersect and create a multi-layered conversation, not a simple binary result. This is why this episode matters. With me is Dr. Manish Motwani, a leading cardiologist whose practice spans prevention and long-term heart health strategy. He sees the real impact of silent risk and the transformative effects when prevention becomes front and center. Together we'll question what we monitor, why it matters, and why redefining our framework around our inner biochemistry and other measurables might be the most powerful tool we ever have for heart health. Mani, welcome back to Ageless.
Thanks for having us back.
So we had a lot of different questions about the calcium test that you did when we looked at my own coronary arteries and my heart. I think there's been a lot of interest. The first question was, do people under 40 need to be having a calcium test?
Okay, that's a good question. It's a key question. So generally, the test is indicated for men over 40 with cardiovascular risk factors and females over 45 with cardiovascular risk factors. So the obvious question is, why not younger? And the answer is that your body doesn't begin that calcification process of the plaques till that kind of middle age bracket. Okay. So if, for example, you had one at 35, you might have lots of non-calcified plaque, very fatty plaque deposition in the arteries that the body hasn't had time to calcify as yet. So that might say your cal score is 0.
Because it's not showing up.
Because the body's not calcified that plaque as yet, it doesn't show up. So a result when you're that young would be misleading. Okay.
So it's like giving a false negative.
Exactly, false reassurance. Okay. So what should a younger person do? Well, if a younger person really made the case that they really need to know what's in their arteries, what their plaque burden is. So it would have to be, someone, for example, who had familial hypercholesteremia or lots of risk factors. Because generally when you're young, you are healthy, so we don't need to be too invasive. But if there was a scenario such as that, then they would have the full coronary CT angiogram.
So those young people who know that they've got a strong family history of high cholesterol, but they might seem really fit and well, and indeed their family members might be fit and well, which test should they be thinking about having?
So what the young individual should be doing is knowing what their blood pressure is, knowing what their heart rate is, knowing what their cholesterol is. These are all numbers that are neglected. So before we get to imaging them or doing any complicated tests, if their cholesterol is high, we've already got an answer of that needs to be tackled. Okay,
right.
If all those other numbers are good and they're leading a healthy lifestyle, then that's probably good until they reach the age of 40, which they can clock into these more advanced diagnostics.
Got it. I think cholesterol can be really misunderstood.
Definitely.
Would you say that even though we've been talking about cholesterol for decades, it's still wildly misunderstood?
Yes, it's all over the place, really.
Yeah.
And you can make it as complicated as you want, to be honest. But, I like to think about things simply. So, I mean, cholesterol is an integral part of all our body cells, okay? It's a lipid that sits in the cells. It's important structure of all of us.
Cell membranes.
Exactly.
Yeah.
So we do need it. You don't want your cholesterol to be 0. But if you have excess cholesterol or your body doesn't handle cholesterol well, then it puts the surplus down in the arteries, okay? Now, usually it doesn't just put it down in, completely normal arteries, there's usually other risk factors as well. So, for example, if you've got high blood pressure, that high blood pressure is kind of abrading the inner surface of the arteries, creating a roughened surface, and cholesterol can deposit there.
Okay, so that rough texture on the endothelium is just, so it's wanting to cling onto it.
It's just finding a nice home for, the cholesterol deposits there. So it's not as binary as, high cholesterol only, is, totally bad. It's usually a combination of risk factors. Okay, but cholesterol is a very strong one. So there are three main cholesterols. The first is the total cholesterol. Okay, so generally we'd like that under 5. Okay, and then there is LDL cholesterol, which is low density lipoprotein. This is the very bad cholesterol. Okay, this is why it's important to know this subgroup of cholesterol. This is the one that is very atherogenic and gets deposited in the arteries. So generally we want this LDL level to be less than 2.
Okay.
And then there's HDL, which is kind of the opposite of LDL is how I think about it. And this is a little bit protective. Okay, this stops LDL being deposited. It balances out the LDL. Okay, and we want that more than 1. Okay. So some people think of LDL as lousy cholesterol, L for lousy, and HDL as happy cholesterol, H for HDL.
That's useful.
But I'd rather your total cholesterol was a little bit elevated, but your LDL low, than the other way around. So it's really important when your doctor or someone tells you your cholesterol's okay, first to know the numbers, and second to know that breakdown. You really want to know your LDL. It's really important.
Are there any other really topical measurements of cholesterol at the moment? Because I'm hearing again in the health span and longevity space, lots of different quotations. What is it that you want to bring some attention to in terms of cholesterol? Recently,
attention has been drawn to LPA, okay, lipoprotein A.
Yep.
Now, although the other types of cholesterol are largely modifiable to some extent, you can do things about it. You can exercise, you can do some diet changes, which won't change everything, but will help. LPA, lipoprotein A, is completely genetically driven, okay? So if you have a family history of coronary artery disease, this is really important to know what your lipoprotein A is, because if that is normal, you might de-risk that family history that you've got. You might be a bit more relieved. And equally so, if it is high, although you can't do anything about it, okay, you cannot change the genetically programmed risk, okay? It's knowledge is power. So knowing that there is this risk should motivate you to address the other potentially modifiable risk factors. So if you smoke these days, stop smoking, okay? Get your blood pressure under control, exercise, healthy diet, those sorts of things. All those become much more important if your lipoprotein A is elevated.
How do you measure lipoprotein A?
So blood tests. So, people think all these tests are complicated. Cholesterol, blood test, LPA, blood test. Okay, very simple, straightforward.
So if somebody was a smoker and then they stopped smoking, would you expect that to potentially help that measurement?
Yeah, I mean, it's never, the message is never too late to stop smoking, okay, as a general principle. We used to say, if you stop smoking when you reach 30, all's okay. That's not quite completely true.
Sure.
You don't want any plaques in your coronary arteries, okay, if possible, okay. Every plaque is a risk of heart attack. Any of those plaques, they're like volcanoes, they can rupture. So the more plaques you have, the more risk of heart attack you are, okay. So why, entertain that risk, okay. So stopping smoking, if you can, with the various help that's available, reduces your risk of new plaques forming, okay? And smoking is pro-inflammatory. So the really dangerous plaques are those that are inflamed, okay? And smoking really kind of promotes inflammation in the body and in that atherosclerosis. So it's more, the plaques that exist are more likely to rupture.
Does smoking impact the calcium that's laid down?
So the calcium is really your body's response to the fatty plaque deposition. So in your artery, the cholesterol and plaque deposition starts non-calcified. It's really kind of fatty, watery plaque. And then the body sees that, doesn't like it, wants to stabilize it, and puts calcium down. Okay, so that becomes a more stable plaque. So the calcification is actually good. it can get a little bit carried away and add to the bulk of the plaque, which can narrow the lumen of the artery. But in general, calcified plaque is better than non-calcified
So what's
plaque.
the smoking doing to it?
So the smoking is pro-atherogenic in general. So the smoking...
So just generalised?
It's increasing the amount of plaque that gets deposited.
Because of the inflammatory response there?
It causes inflammation in the wall, in the inner wall of the arteries, and makes it a really kind of nice surface for cholesterol to embed.
Yeah.
It also adversely affects your cholesterol profile. We talked about total cholesterol. We also talked about the balance between LDL and HDL. So smoking is associated with higher LDL levels. So I mean, that's a very modifiable risk factor that can be removed. Smoking does one other thing as well. It can also disrupt the endothelial function of the arteries. Okay, so we talked about previously how our arteries need to be elastic.
Yes.
They need to respond to stimuli. They need to relax when they can. Smoking, contains all sorts of substances that deplete the natural kind of nitrates in the arterial wall, and that means that these arteries become stiffer and can't respond. So that can have a deleterious effect in the coronary arteries, but also in the bigger arteries of the body. So you find people who smoke have high blood pressure because their arteries have become stiffer. They're not as elastic. So really, smoking, you're aging more, not aging less. That's what it's doing. It's destroying the elasticity in your arteries, increasing your blood pressure, adversely affecting your lipid profiles. It's bad news all around.
Let's talk about another hot topic, which has got to be hormones and heart health. I want to know, from a hormones perspective, hormone imbalances, how important are they for cardiac health?
Okay, so I mean, that's a big topic. We can touch on some aspects. So if we start with females, estrogen is important in maintaining that vasomotor tone, so how your arteries and vessels respond to stresses. And that's driven by endothelial function. Okay, so that's endothelium is the inner lining of the arteries, and that endothelial layer is produces lots of chemicals and signals, and estrogen is important in keeping the integrity of that endothelium and the kind of overall function of the arteries, how they dilate and constrict. Okay, so a couple of things can happen as estrogen drops down in a woman's life around the menopause. One kind of severe kind of problem that could be, if we go from looking at the most extreme example, the elasticity of the arteries becomes less efficient, so they can be more prone to tearing. Okay, so that's a condition called coronary artery dissection or spontaneous coronary artery dissection.
Wow, that's really serious.
That is a serious one. So not being alarmist, but that is a presentation we do see in perimenopausal or menopausal women.
Okay. How do they present?
Well, typically, they might have been doing high-intensity exercise, and the sheer stresses through the coronaries can cause a tear in the arteries. That presents like a heart attack. Okay. Now, I bring up this example not to scare everyone, but this is to show that even something we kind of think cannot be related to the heart, estrogen, is having an effect on heart health and the whole cardiovascular system.
Manny, this is why I've invited you on to talk about this specific point, because there's so much discussion around menopause and hormones, but actually I think that there's a smaller lens on the impact it has on cardiac health.
Yeah, definitely.
And it's so important to discuss it.
Well, I mean, it's more than that. If you look at most of the heart studies, all the classical heart studies that looked at heart attack, statins, treatments, the number of women in those studies is, it could be 10, 20%, 80% were men. Okay, so a lot of the treatments, we use have been studied predominantly in men. Okay, and women are very different, as you know. Okay, so they're understudied. Okay, and we don't know completely whether all these treatments, affect women in the same way. Okay, so it's really important that this issue is coming to light and women's health is getting more attention. Studies being specifically done in women. When we review papers and studies, we now say, well, why is only 20% females? Okay, they're working, they're not just at home. Why can't they be part of these studies? And that seems to have been dismissed in the past. And females present very differently sometimes with their coronary artery disease. They have more atypical pain.
Okay.
So the textbook nature of, classic vice-like chest pain is often a bit different. They can present more with shortness of breath sometimes, different types and characters of pain, sometimes fatigue. So there's a diversity, in their symptoms more so than there is in men. It's important to realize all of that.
So for those women who might be getting those sorts of symptoms or have strong risk factors or a family history, where would you guide them to? Again, would it be know your numbers?
Yes.
And look at those lifestyle measurements, but also perhaps a calcium score?
Yeah. And I mean, they shouldn't dismiss their symptoms. If just because their chest pain is a bit atypical, it might be dismissed. It doesn't look like the man in the textbook, who's got a vice across his chest. Okay, so they need to be a little bit persistent and say, well, look, this is a symptom that's interfering with my daily life. There's something not right, and get tested, see the cardiologist, and move through those pathways.
I couldn't agree more. Yeah. Many of my female patients will mention these kind of almost not soft
vague
symptoms, but vague.
Yeah.
And it can be assumed that it's got nothing related to anything to do with cardiac, and again, overlooked. And, we see in medicine so frequently so many groups that are underrepresented in terms of clinical trials.
Absolutely.
Be it in terms of ethnicity, in terms of 100%. Gender, etc., in terms of other types of morphology and physiology. So I'm, again, glad that this is coming to the light in terms of this specific subject matter that we're discussing today. What about men? Because obviously a lot of talk about menopause. What about menopause?
Well, exactly the same, really. I mean, just going back to females, what happens as the estrogen drops is that there's a shift in their cholesterol profiles. So their HDL, which, as you know, is slightly protective, that drops, and their LDL goes up a little bit. So it's a time of life when they're more atherogenic. There's more chance of cholesterol buildup, as well as those other changes that we mentioned. Yeah. And the parallel from that, actually, thanks a lot to all that we have learnt about menopause and changes, is now being seen in men. So men, when they reach that time in age, testosterone is dropping. We see the same shifts in their cholesterol profile. Okay, HDL drops, LDL goes up. So it's a time when senescence, aging, is happening, and one manifestation of that is more cholesterol and plaque deposition, and it partly relates to this change in hormonal balance. We don't know everything about it as yet, but that's part of it for sure.
And again, as a basic principle, would you suggest for those people who are going through perimenopause, go and get your cholesterol checked?
Definitely.
And get the differential of that cholesterol
100%,
checked?
100%, yeah.
As a cardiologist and a general physician, I want to know from you, what's been the most exciting development that you think is going to benefit wider society?
I think this year and last year, really, we've seen the emergence of multiple new classes of drugs that are particularly tackling the metabolic pathways, insulin resistance, obesity, and amongst those, the GLP-1 receptor agonists. So like Ozempic, I think they're really transforming this area that we've been talking about, primary prevention, cardiovascular health. We're finding more and more indications for these. But predominantly, in terms of reducing obesity, I mean, that's one of the biggest risk factors that needs to be modified as a population, okay? It's sad to see children and adolescents obese, in a developed country. We know that this is, very bad for cardiovascular health and systemic health, and we're doing it to ourselves. Now,
overfed and undernourished.
Exactly. Now, it's sad that we've had to reach into the pharma box to do something about it.
It is.
When we know exercise, healthy diet are, the main drivers which could sort this out. But there is sometimes, and partly in the evolution of man, there is a genetic makeup. There are changes in metabolism that are happening, that sometimes we do need this additional assistance. And moreover, when obese patients or overweight patients, it can be difficult to get out of that vicious circle that they get themselves into. They actually, most patients I see do want to lose weight. They know they have to lose weight, but just being told they need to is not actually that helpful. How are they going to exercise when they get breathless and they can't actually do it?
Very true.
Okay.
Very true.
So if these medications can get them out of that vicious cycle, if it can help them lose a little bit of weight where they can then get back to exercising and healthy diets, that's huge. Okay. And what I find fascinating is, it's become, Weight Watchers in the US has gone bust. Okay, such as the success of these medications,
it's insane.
Which is insane. So I think this will really have a major impact on, health in the developed world, which is sadly where obesity is affecting us.
It's really interesting that you're, from a real medical perspective, seeing such benefits with your patients in those different cohorts, because I think it perhaps hasn't had as much of a spotlight put onto that.
Sure, yeah. I mean, it's been mentioned in the diabetes world, in terms of treating obesity specifically, but it's also massive in heart health. One of the things that's underappreciated is if you're overweight, obese, there's a lot of pressure on the chest, and that's literally squeezing your heart. So people turn up with quote unquote heart failure, where they've been told they've got symptoms of heart failure, and they do have symptoms of heart failure.
Okay.
They're short of breath, they're collecting fluid.
Right.
But actually, when you scan the heart muscle is still contracting well, but it just hasn't got enough room to stretch because of the pressure of fat around it. So losing weight, however they can do it, often has a dramatic impact. And fortunately, we have these medications at our disposal now, and we're seeing significant changes there.
I'm interested, just on that point, have you scanned many patients before and after GLP-1 where you've seen a change in their visceral fat around the heart?
So there are some studies that look specifically at the impact of drugs like Ozempic on patients with heart failure, like the STEP-HF trial.
Okay.
And, all the data so far is showing, significant benefit. What we haven't been able to do as yet is get to the nitty-gritty of those mechanics of what is actually happening. Like, is it, as I say, the muscle's able to just contract and have better strain, or is there some improvement in the integrity of the heart muscle that's giving it a bit more oomph? But in general, tackling obesity is definitely helping overall cardiovascular health, both in heart failure and in other heart diseases, because it allows the patient to get back to exercising and giving them that little push back into where they can motivate themselves, because it can affect your mood. You can get very low when you're trapped in that vicious cycle, and it's very hard to get back into the zone where you can actually do something about it.
I think it's even beyond a kickstart, isn't it? It can really be transformative. And I'm sure you'll agree with this. It's such a huge topic. Yeah. It has in terms of the impact on overall metabolic health, I think there's a lot that we still don't know and still don't understand.
100%.
But as you say, there's positive aspects to it. But both of us who work in research, I think we still need to see the further impact that these drugs are going to be having on wider society. Yeah. So what I've loved about today is there's been so much balance in terms of your message. It's not just going to a drug. It's not just going to, these more interventional aspects of medicine. It's about, again, just everyday lifestyle factors that people can genuinely, practically apply.
I think that's the point. To do things in your daily life, like I've said before, taking the stairs, these little things, but done consistently, are what will help. Okay, don't believe that something in a bottle is going to, completely change your life. It won't. We've seen those movies. It doesn't work. Okay, it always goes wrong. So it's a balance, and little changes all add up to an overall de-risk situation.
Yes, well, Mani, thank you so much for all your valuable insights. Really appreciate it.
Thank you.
What strikes me from today's conversation is that cardiovascular health is never static. It's constantly shaped by hormones, nutrition, stress, and lifestyle. Aging isn't one event, but an accumulation of choices, each one leaving its imprint on the arteries that sustain us. So what can you do this week? Start by noticing patterns and noting your numbers. Track how your energy shifts through the month with your sleep or your exercise. And if you haven't already, you don't necessarily need expensive health trackers. You can begin a simple health journal, recording blood pressure, mood, movement, and diet. These small acts of observation can uncover hidden trends long before they become risks. My philosophy has always been that true longevity is an alignment, a coherence between how we look, how we feel, and how our biology is unfolding beneath the surface. If you found this conversation valuable, please subscribe, share it with someone you love, and let us know the questions that you want answered in future episodes. And as a thank you for being here, you can redeem an exclusive free skin consultation and 15% discount on the One Dermafacial with my team in my clinic, One Aesthetic Studio. Simply follow the link in the show notes and enter the code HGL15 at checkout. So I leave you with this question. What could your heart be telling you about how you are living today beyond what you feel? Together, we are reframing what it means to live and age well. I'm Dr. Jonquille Chantrey, and this has been Ageless.